You're listening to In Network, Nordic's podcast series where we explore healthcare and technology with experts from around the globe.
Hello, and welcome to the In Network podcast feature, Designing for Health. I'm Nordic's Chief Medical Officer, Dr. Craig Joseph. I recently sat down with Stefanie Simmons, Chief Medical Officer at Dr. Lorna Breen Heroes Foundation. We discussed Stefanie's background, the impact of mental health stigma involving healthcare professionals, and the WellOps approach, which provides strategy for improving healthcare workers' well-being. We also talked about the foundation's work to reduce burnout and foster collaboration among healthcare organizations to improve workforce wellness. Let's plug in. Dr. Stefanie Simmons, welcome to the pod. How are you today?
I'm doing great today. Thanks for having me.
Where do we find you today? Where are you recording this podcast from?
Today, you find me in the not so snowy climes of Southeast Michigan. So I live in Ann Arbor, Michigan.
Awesome. So is it warm? That's what I think all of our listeners want to know.
It is, relatively speaking, for December in Michigan. It is warm. It is in the high 30s. So everything's melted and it is gray and mushy, which is sort of situation normal for our winters.
That's definitely better than Arctic. So we'll just go with that. We'll go with the global warming of mushy. So you are the Chief Medical Officer for the Lorna Breen Heroes Foundation. Once you give us a little rundown as to how you got there, I'd like to always start with nursery school or preschool and just take us year by year from there to today.
Well, I am an emergency medicine physician by training, and I got there in a bit of a roundabout way. I was a history buff and thought I was going to be a history professor. When I was in college, I loved learning about why things happen in society and why big themes and changes occur. And I still love that. I decided late in my undergrad career to go into medicine and late in my medical training career to go into emergency medicine. In fact, I matched into anesthesiology and then switched. One of the few physicians to switch out of anesthesiology.
Yeah, that's kind of unheard of.
I loved the sort of wild environment of the emergency department. It had a lot in common actually with what I liked about anesthesiology, but just also really interesting patients to interact with in their most vulnerable moments. I started a fellowship in the Robert Wood Johnson Health Policy Fellowship, and it was around that time that I experienced a well-being crisis. I had postpartum depression from my second child, and I'd been in school for, at that point, a very long time. And I had this crisis of, when am I going to start doing all of the things that I've been training to do? I came to the decision to stop my fellowship and to work for the community partner in my residency program as an emergency medicine physician and just try everything. And that was my explicit goal when I took the job, is that I was going to work 2/3 time clinically, and I was going to try everything and find my hobby at work. And so at the end of that year, I was the hospital lead for the Keystone Quality Initiative for the hospital, and very interested in the culture of safety between teams and how we get safe environments that great patient care can happen. And what are the human factors in that? How do people work together to make that happen? And my boss at the time offered me the job of the chief quality officer for the group. And I said, I think you can find someone else to do that, but you don't have anyone looking after the patients or patient experience. So I started as the medical director of patient and clinician experience with that group. It was about 900 doctors in 30 hospitals in emergency medicine. And as that group grew, acquired, merged, as has happened so often in healthcare around the environment, my role grew. And so in the spring of 2020, I found myself as the vice president for patient and clinician experience in a group, with 20,000 physicians, staffing 100 hospitals in emergency medicine, anesthesiology, radiology, women's, children's, and general surgery. Really, on the eve of the pandemic, caring for the professional well-being for a large number of critical care and critical access healthcare workers in emergency medicine, ICU, and the hospital floors in the Northeast and the Panhandle in Texas and the Midwest, who needed a lot of attention to their professional well-being in the next few years. So as I was doing that, the foundation was born, and I reached out to the co-founder, Corey Feist, and let him know the work I was doing in my organization and asked to be of service. He put me on his board, and I did some work with the foundation over several years, and then last year became their chief medical officer.
So tell us about Dr. Lorna Breen and the foundation. What's it all about? Why did you want to become involved, and what do you do?
Dr. Lorna Breen was an emergency medicine physician. She worked and was the department head in one of the busiest hospitals in New York City, New York Presbyterian Hospital. She was faculty at Columbia, and by all accounts was a wonderful friend, was a wonderful aunt and sister and daughter, and really cared a lot about emergency medicine, about caring for patients, and about her colleagues. She was called back from a family vacation with her sister, brother-in-law, and their kids, the Feist family, to care for patients in the first few days and weeks of the pandemic. And I think we all have memories of what the images looked like coming out of New York City during that time. Like many healthcare workers during that time, she was working 20 hours days, caring for patients, also caring for her colleagues, making sure that the operations in the department were running effectively, that people had PPE and were staying safe. She got sick with COVID, and like many healthcare workers, she came back. She came back as soon as she was technically able to come back and was afebrile for 24 hours. But as we know now, just because you're 24 hours afebrile doesn't mean you're fully recovered. And she became profoundly fatigued, had a hard time keeping up. And there was this overlay, in addition to the fatigue, of just real concern that she was failing her colleagues, and that they would see that she couldn't keep up, and that there would be judgment there. She ended up being evacuated by her friends and family to her childhood home of Charlottesville, Virginia, to receive care after essentially becoming catatonic. And she received her first ever mental health care there. And she expressed to her family that she was terrified that because she had received mental health care, she was going to lose her license to practice. She was going to lose her credentialing at the hospital, and she would no longer be able to be a leader in her field. And she died by suicide. Less than 12 hours after her death, the New York Times published an article about her death, including the cause, against their family's wishes. And as you might imagine, that was traumatic for them. But there was a unexpected side effect of that, which is the outpouring of support and of personal messages from healthcare workers across the country saying, Lorna's not alone. I'm afraid of this too. This is a real issue. We are all struggling. This is, by the way, has been going on forever, not just during the pandemic. Healthcare burnout has been a real issue, and we don't have a voice. And so her family, her sister and brother-in-law, Jennifer and Corey Feist, chose to start the foundation, the Dr. Lorna Breen Heroes Foundation, for all healthcare workers, with the vision of creating a world where seeking mental health care is viewed as a sign of strength, and of helping to advance solutions that can provide an environment where healthcare workers can find joy in the practice of their mission and of their profession. I don't think I need to say why I would love to get involved in that, right? Doesn't that sound like a huge—
Well, when you put it that way, that does sound like something that we would all want to be involved with. And so I withdraw that part of the question. No, it's a kind of a touching, obviously sad story. And as a physician, I totally see how it happened. I remember as a resident pediatrician being told by a more senior pediatrician that if I wasn't sick enough to be admitted to the hospital, then I was okay to come to work. And that was it wasn't written down anywhere, but that was certainly the idea that hey, when you're not here, Everyone else is doing a lot more work. Forget about the effect on the patients. It's there's an effect on your colleagues, and you don't want to let them down. Certainly, don't want to let your colleagues down. And it's nice to think about, but that's not reality.
But there's this in the service of in really instilling this professionalism of caring for patients, of being there even when you're tired, even when you'd rather be doing something else. There's this really insidious message that sneaks in, which is um, you are expected to sacrifice every part of yourself to this profession. And in fact, if you take care of yourself, if you maintain your identity, if you care for yourself, if you have a medical or mental health condition, that is in fact unprofessional. Healthcare workers are human beings, and the system has been designed to get the result that we're seeing, which is devastatingly high levels of burnout, of mental health conditions, and suicide of healthcare workers. So, if the system's designed to get the results that you're getting, you don't like the results, you need to change
Okay. So one aspect of that was, and you just so eloquently talked about it, was Dr. Breen's concern that since she had received mental health care as a patient, that she was now uh, almost officially not a doctor anymore, that she would lose her license. Is that true? What is the reality there?
Yeah, the reality is it depends and it's complicated and it's not universally consistent, all of which combined to exacerbate, Lorna's uncertainty. The rules are really unclear and unknown to most people. So one of the first thing that the foundation tried to do is to make the rules transparent. And so we looked at the state medical board licensing applications and said, hey, are there questions on this application that ask about any diagnosis or history of mental health condition? And we made a map and said, here are the states where they don't ask. And here's here's the states where they do. And the irony is New York State Medical Board doesn't ask about a history of mental health conditions. But at that point, there were, you know, 39 states that did. And you can imagine the confusion where there's no place you can go to look that up. There's this pervasive culture around whether it's okay. And there's other places that these questions are asked outside of medical boards. There's hospital
Right.
credentialing, professional liability applications, payer applications. And so one of our initiatives has been to systematically educate the folks who are asking these questions about the impact that it's having on healthcare workers, and then to provide a way forward, a toolkit on how to audit, change, and most importantly, communicate those changes to the healthcare workforce so that they feel safer to receive care. And then as a foundation, to communicate those changes globally and help to inspire changes in the state licensing boards of all healthcare, licensed healthcare workers, and the credentialing applications of all hospitals.
Yeah. It's kind of amazing that once you've seen one, let's even if you just focus on state license, once you've seen one state license application, you've seen one.
Yep.
They're all different, much like we need a driver's license. And whenever we move to a different state, we need a different driver's license. That's same for physicians in terms of the ability to practice medicine. And as you mentioned, it's not just the states, it's every hospital has their own application and every insurance company has an application, and they can all be asked these questions. And most of us, there's no way we're going to remember which asked, and certainly we're probably signing a statement saying that if we ever receive these services, that we agree to notify them. And so transparency is a gift if you can achieve it. Sounds like.
There have been organizations who have been advocating for these changes for some time, like the Federation of State Medical Boards, Federation of State Health Programs, the AMA, and there had been some progress. So when we started this work in 2022, there were 19 states that had state licensing applications consistent with best practices. Now there are 29. So in 2 years, there's been a lot of change, and we know that there are many more in process that we will be awarding the all-in credentialing and licensing application badge to. So we created this badge because we wanted that communication component to really be front and center, since healthcare workers will assume the worst in the absence of information because that's the economically safe thing to do, right? We created this badge. We've been able to award it to 29 states. We've got many more in the process. And we've also been able to award over 400 hospitals the badge for their credentialing application change. So we are seeing increasing numbers of states and of organizations taking up this challenge and saying, yeah, these questions don't really protect patients. And we also know that they inhibit healthcare workers from receiving care. It doesn't, by the way, prevent healthcare workers from having mental health conditions. It just prevents them from receiving care.
Yeah, if only it did the former. That would be pretty cool. So obviously one big aspect of the work of the foundation is that transparency and kind of pushing entities like states and healthcare systems in the right direction. Another thing that the foundation works on is physician burnout or clinician burnout more general. What do you see as the kind of the connection between clinician burnout and mental health? And are there how do we what are the solutions that can take us in the right direction?
It's a great question. And part of the issue of work and professional well-being has been a confusion of terms, right? You have well-being, professional well-being, wellness, mental health, burnout, and they are all related, but they need slightly different solutions. And so the way I like to think about this is in grouping it by the solutions and the actions that are needed. So, you can imagine mental health conditions, over here, they require removing the barriers to access for mental health conditions to licensed and credentialed healthcare workers, screening for suicidality, and making sure that healthcare resources are available. And by the way, mental health resources that are culturally competent for healthcare workers, because it's a unique environment. And it can be very hard to start with a counselor or a therapist who has no background in that environment and the type and degree of stressors that are experienced. I hear from healthcare workers all the time that they're reluctant to talk about the types of traumas they've experienced because they don't want to traumatize their counselor. And so having a counselor or a therapist who has that background can be really helpful. On the other side, you have burnout. And burnout is an occupational phenomenon. It is a mismatch between work resources and work demands. And there, when you add in patient care to that, there's an additional component where you witness human beings suffering because of that mismatch. And that also causes moral distress in the healthcare worker. So, I'm an ER doc. You can take the girl out of the ER, but you can't take the ER out of the girl. So when I think about burnout, I think of a wounded patient in front of me. That's our healthcare workforce. We know over 44% of them are experiencing burnout and severe distress. So what's the first thing you do when you've got a wounded patient in front of you? You hold pressure. Okay, you gotta slow the bleeding. That's individual support. And so we need systems and we need processes in place to provide individual support for healthcare workers, whether that's peer support, coaching, support during litigation, resilience training. All of those are individual support interventions. If that is all you do, the patient will still die eventually because you have not addressed the source of the bleeding. You have only slowed it down. And so you need to go to the source of the bleeding and address those operational and environmental issues that are causing the work demand mismatch, that are causing patient harm and putting healthcare workers as the last remaining barrier between their patient and the system. Okay, so looking at removing administrative burdens, streamlining processes, making sure that the EHR works for healthcare workers and patients, and not just for billing and insurance, right? And so all of these processes of really fixing that environment are ultimately the operational changes that need to occur.
Yeah, it's a great way of thinking about it. Because I thought all we needed was maybe some pizza and some resilience
Intense.
classes. But the idea of that, hey, if you're bleeding, we need to do two things: one, apply pressure, and two, stop the bleeding. And doing one without doing both is not going to ultimately solve the problem, and it will just crop up again and again and again. So let's focus in then on some of the systemic things that you had mentioned, um, that kind of contribute to burnout. How do you think about design? How do you design programs, interventions, operations that help move us in the right direction, kind of fixing the problem of the bleeding? Are there some programs that you can kind of point to and say, well, this seems to work?
It's a great question. And the first thing I would say is I would never design a system, but what I would be happy to opine on is how organizations can harness the wisdom of their healthcare workforce to design systems. And so that ends up being a key component of this. There is incalculable wisdom and experience in the healthcare workforce. And they know where the sticking points are in the processes because they are pebbles in their shoe, right? They can identify those. They often have great ideas on how they can be fixed, and their voices need to be included in every step of the way. So there's this idea of the triple aim of healthcare quality, right? Good patient experience, great outcomes with efficiency, financial efficiency. And the quadruple aim includes the impact of that work on the workforce and harnesses the knowledge of the workforce. You can harness that apparatus and just take a 10-degree shift and look at the outcomes on the workforce to instantly have dozens of healthcare worker well-being projects. It's more of a philosophical shift than it is a completely new process or a completely new apparatus. And what we've done at the foundation is we've developed something called Well Ops, which is a process that you can use as a hospital or health system quality improvement process that makes sure that that voice of the healthcare workforce is being incorporated in each step of the planning, of the operationalization, and of the sharing of results in quality improvement and other operational projects.
So tell me more about Well Ops. What is that?
So W stands for who's on the team. And it really is, who are you including in your planning team? And that needs to include your frontline healthcare workforce. It also needs to include, quality improvement folks, the clinical and operational leadership of the organization. E stands for evaluating your current state. And that means both quantitative and qualitative evaluation. So, really listening from the frontline workforce about what are those pebbles in their shoes? What does need changes? What is the current impact of the process or the operative procedure? And then also looking at the data that's available, whether that's EHR generated data. L, the first L, is to learn what's possible through case studies, through best practices, through experts. And the second L is to really lean into measurement and think about how you're going to measure the results in a way that is meaningful to the healthcare workforce. Then you've got the dash in Well Ops, which is take a pause, make sure the problem's still the right problem, make sure everybody on the team still agrees, because ops is going to be operative planning and producing results. And then once you have those results, you know what's worked and what hasn't worked, you're going to share those results. And you're going to share what works, not just within your organization, but among your hospital colleagues, within your state, or across the country, because we need to reproduce what works. There's enough problems and enough people facing the same problems that we need to start sharing where we have success.
Yeah, I think it's like an arrow from learning what's possible. Learning what's possible only happens if others are sharing what they've done, and also being open. Many times when I have the CMIO hat on, I've had physicians and other clinicians, everyone come and tell me what they, hey, I need a new order set. Hey, I need a new documentation flow sheet row. Or often they don't know what's possible. so they're not actually asking for the right thing. And what we really need to do is go back a couple steps and say, hey, what's your problem? And then let me pose some solutions to you. And to me, it's a very similar thing, right? I think to your point, like if you don't know all the different choices that are out there, then you couldn't possibly be likely to make the right choices.
That's right. And so this isn't putting the burden of the operative change on the frontline workforce, but making sure that their voices are heard and that the the communication loop is closed. But there's not the closed communication of, hey, we've put this process in place because we heard that this was difficult. We heard that this was one of those pebbles in your shoe. How is it working? Has it helped? Right. And then that serves two purposes. One, you might find out the answer is no, in which case you need an iteration on the process. Or the answer might be yes. And at that point, you've communicated to a frontline healthcare worker that their feedback mattered and you made a change based on it, and and it's made their life better. And that becomes a virtuous thing.
Yeah, absolutely. Well, one of the things that you've talked about is normalizing conversations around mental health, specifically in the healthcare industry. How does one go about doing that? Whether there are regulatory or legal requirements or not, there's still that stigma. What can we all do to kind of work towards getting rid of those stigmas?
So I think of stigma three ways in healthcare. The first way is internal. What does it mean about me if I need help? And healthcare workers are achievement oriented, often compulsive.
Guilty,
They
guilty.
they don't want to get anything less than an A plus on everything. And so part of this is an inside learning, right? And an examination of what it means to be human and vulnerable and what's okay. And it's an inside job. You have to do that work first. The second part of stigma is external, and it's what we fear others will think of us if we are human and need help. And part of what we can do there is if we have an experience that we can share from a position of strength, share it appropriately in the appropriate setting with the appropriate people so that these stories of humanity become more common. In fact, that was the thing that helped me when I was struggling was one of my colleagues who was senior to me who I really admired and looked up to, shared with me that he also struggled with anxiety. And I thought, oh, well, this guy who's like totally crushing it here in the ER, who I like and respect, has dealt with this. Maybe it's okay for me to share and get help with what I'm dealing with. Well, we also need to think about how we talk about mental health when it's a patient, because our colleagues hear that. And we still have societal stigma around mental health conditions and substance use disorder that show up in the language we use in medicine. So understanding, educating ourselves and each other around, best practice language to use. The third area of stigma is institutional stigma. So what are the policies and procedures that we have around healthcare workers with health condition, with a substance use disorder? Are we equating those with a moral failing, or are we treating them like we would treat a healthcare worker who developed a physical health condition? And I would argue that there's no parity in how we treat those conditions right now. The foundation is launching a Stop the Stigma campaign in March of 2025. And we're looking at how we can ensure mental health access for healthcare workers.
So what's the answer? Is it B? I always put B.
I'm a C girl myself.
Are you C? Okay.
Yeah.
Well, I mean, I think that's very helpful for everyone to hear that, I've been semi-successful, you've been very successful, and we've had different answers to our standard questions. But seriously, how does the foundation work with healthcare institutions, kind of redesign systems to promote well-being, to reduce burnout, to get rid of stigma?
So we have two signature programs, and the first is the All In Champions Challenge badge for licensing and credentialing. And we've gone into that, so I won't belabor the point, but we do provide a lot of technical assistance to organizations, to state boards, to insurers, anyone who has these questions on their credentialing or licensing applications. We will provide technical assistance. We also work with states and other organizations to help them advance in their professional well-being journey. There's two ways that we've done that. One is through the Impact Wellbeing Guide, which is a leadership guide for hospitals and health systems that we co-produced with the CDC and NIOSH. It really has the first 6 steps that hospitals and health systems should take, and it's a self-guide. If you wake up on any given Wednesday morning and you want to address professional well-being, it can feel like you have to fix the US health system, which is a tall order of business. So this is like, there's your elephant. Here's the first 6 bites. Okay. And here are some people you should invite along with you. What we've found is that if you can put organizations together in a learning community to do that work, it's very helpful. So we have led statewide initiatives, forming learning communities in at a state level, and bringing the hospitals and health systems in the state together with the professional organizations, the hospital association, nursing association, medical association, the health informaticists, um, and really look at, and the pharmacists as well, and really look at how as a state we can address the issues of institutional stigma, making sure that there is a common vocabulary around the drivers of burnout, what can be done to address them, and then putting these organizations together in learning communities as they go through the well up steps so that they have people to bounce their ideas off. We get national experts in to speak with them about different components of the steps and to provide that technical assistance as they go through the process. And then this also assists with the sharing of what works where it works. Because in these learning communities, when there's a barrier that's identified or a best practice that's identified, they can share together and everyone learns. So we talk about statewide cooperation. And when it comes to the well-being of the workforce, it's definitely an area where cooperation is mutually beneficial, and the rising tide raises all ships.
I like cooperation. That's a good one. So we have listeners who are healthcare leaders and clinicians. How do they learn from the foundation? How do they become more involved if they're interested?
We have a number of ways to learn and become involved. So first, I'd encourage every healthcare leader to go through the audit, change, and communicate process. On our website, under Remove Barriers, we have a toolkit. I think the link will be in the show notes of how to do that audit, change, communicate process and go through your credentialing applications, make sure that they adhere to sort of those best practice standards. If your organization is at a level of maturity where you want to continue that professional well-being journey and really build readiness and a more mature approach to professional well-being, the Caring for Caregivers program is available for organizations, and we can help provide that technical assistance. And the Impact Wellbeing Guide is also available online, paid for with your tax dollars through the U.S. federal government, and so free and freely available. You can. There's also, for individuals who are interested in getting involved, we have an ambassador program. So we have about 200 healthcare workers and family members of healthcare workers, sometimes surviving family members of health workers who have died by suicide, who come together and help to bring this message forward, to promote the work of the foundation and bring the message of the foundation to new audiences. And so we always are happy to entertain applications for new ambassadors as well.
Well, that's great. We'll definitely include those links, as many links as necessary, all the information into the show notes. We've learned a lot. At least I've learned a lot. Thank you so much for your time. As we get to the end of our time together, one of the questions we always like to ask is about design. And if there's one or two things in your life that are so well designed, they bring you joy when you interact with them. And so, is there something that's so well designed that when you use it, when you interact with it, you're happy?
The thing that comes to mind and really has brought me really the most joy in my life came about because right after residency, I was sitting doing a grant prep session, probably my 90th or 100th hour working on a grant. And I had this moment of thinking to myself, is this really it? Like, is this all we're going to do? Is just sit here and work on things like this? And at the time, I had a 4-year-old and a 1-year-old. And I thought, I'm going to design a system where I'm very mindfully spending time with my children, and not only on a day-to-day basis, but also taking a trip with them at key moments in their life. And so when my kids turn 5, I take them to Chicago, which is about a 4-hour train ride, and we do American Girl doll and the aquarium and a dinner out, just mom and them. When they're 9, it's Washington, D.C. for museums, monuments, and the zoo. When they're 13, they get to choose where they go. And I've had one child so far choose Alaska and the other one choose Disney World. So, you get a little sense of who they are at 13. And then when they're a senior in high school, they get to choose where they go in the world. And, at this point in my life, I've got a 19-year-old, a 16-year-old, and a 10-year-old. And so I've gone through a number of these trips. And every time I think about that moment in my life where I decided to design a way to build in these vacations with my kids, I'm so thankful that I did, because the memories that we built together, we still talk about. And I look forward to the trips that are yet.
Well, I can't wait to read about it in the book that I'm going to ask you to write. I'll give you a little time so that all of your kids can go through all of their trips. But yeah, that's what an amazing a gift that you're giving both to them and to yourself. That's a great use of design, and it's intentional, right? This didn't accidentally happen. You kind of came up with a plan and then executed on that plan. Well, thank you so much. This has been really enjoyable. I think we've all learned a lot, and most of us have follow-ups now. You've assigned, you didn't know it, but you've assigned homework to us.
I ended up more on the history professor side of things after all. And
You really are a professor, and I'm scared about the test. I'm not sure when it's coming and if it will be multiple choice or essay. Clearly, I'm going to vote for multiple choice. And I will, if I don't know the answer, put B.
no,
Just
C, because I'm the one who will.
Oh, you're writing the test. Okay, C, you are correct.
Well, thank you so
Awesome.
much for having me on. I appreciate the conversation.
Thanks for tuning in. We hope you enjoyed today's episode. For more on Stefanie, follow her on LinkedIn at linkedin.com/Stefanie-Simmons. To learn more about the foundation and become more involved, visit the website at drlornabreen.org. That's drlornabreen.org. Check back for more episodes of Designing for Health wherever you listen to podcasts or on nordicglobal.com. Till next time, we'll see you in network.
If you enjoyed this episode, please leave us a 5-star rating and a review. This helps others find the podcast as well.